disabled Hispanic female with sudden complaints of worst headache of life presents to Del Sol ED on 10/31 of this year, at which time CT revealed subarachnoid hemorrhage with a Fisher grade of 4. She was intubated, then transferred to Las Palmas Neuro ICU. Today is post-bleed day number 6. Patient was extubated during her stay, but had many events in the past 24 hours leading up to reintubation. She was placed preemptively on bicarb drip for plan for angiogram later in the day in an attempt to locate the aneurysm. It appears she became fluid overloaded and could not tolerate laying flat. She was then intubated. However, she was also noted to be retaining CO2, which was causing cerebral edema and elevations in ICP. Based on these complications, plans for angiogram were postponed. Patient's husband was at bedside and was used as a historian. Patient with no known drug allergies does have a past medical history of diabetes, mellitus type 2, hypertension, and migraines. Surgical history includes a hysterectomy in 2000. Denied use of alcohol, tobacco, or illicit drug use. She currently works as a teacher and lives with husband and daughter. Immunizations are up to date, including the influenza, which she obtained this year in 2015. She is on several medications right now, including famotidine, 20 milligrams, Q12 IV. She is on a fentanyl drip to titrate for sedation. Currently, she is on a Lasix drip as well at 10 milligrams per hour. Cardine drip to titrate for systolic less than 160. Clonidine patch, 0.2 milligrams Q7, Q7 days. Labetalol, 10 milligrams Q2 hours, PRN for systolic greater than 160. She is also on hydralazine, 25 milligrams Q6 per NG tube. Amlodipine, 10 milligrams daily per NG tube. She's also on cefepime, 1 gram Q12 hours. Because of her diabetes, she's on insulin detamir, 15 units BID sub-Q. She's also on magnesium citrate, 10 ounces daily per NG tube. Metoprolol tartrate, 100 milligrams BID per NG tube. Tylenol, 650 milligrams Q4 hours PRN via NG tube for fevers. She's on Mucomyst, 600 milligrams BID per tube. Prevestatin, 40 milligrams at bedtime per NG tube. She's also on Albiro Atrovent for RT Q4 hours inhalation. She is also on Keppra, 100 milligrams Q12 hours IV, and morphine sulfate, 2 milligrams IV Q4 hours PRN for pain. As for the review of systems, the patient is currently intubated and sedated. Remains critically ill in the neuro ICU. However, patient's husband is at bedside, which was able to provide some information leading up to the event on 10/31. Generalized, apparently she had no complaints, no fevers or chills. Patient states that she had no real complaints other than a real bad headache, quote unquote, prior to presenting herself to the hospital that day. Denied loss of consciousness, denied trauma, no visual changes, no photophobia, no changes in hearing, no voice changes or sore throat, no shortness of breath or cough, no chest pain, no swelling to upper or lower extremities. Apparently she had no abdominal pain. However, she was nauseous prior to presenting to the ED that day. No urinary changes, no symptoms. Musculoskeletal, no complaints either. Neurologically, she was only complaining of some numbness to her fingertips. Upon physical exam today, this is a critically ill 50-year-old Hispanic female intubated and sedated at this time. Current vital signs 98.4 Fahrenheit temperature. BP is 153 over 59. 73 heart rate. Sinus rhythm on the monitor. No ectopy noted. Respirations 19. 97% O2 set. Head and eyes atraumatic. Clear corneas. Normal conjunctiva and sclera. Normal cephalic. Perla noted. Ventriculostomy tube in place. Dressing is clean and dry in place. No drainage noted around insertion site. ENT, dry mucous membranes, normal nose, normal pharynx, normal sinus. NG tube is in place in the right nair. ET tube at 7.5. Well, ET tube size is 7.5, secured in place at 23 centimeters. Top lip. Her neck is midline, no deviation noted, no JVD noted, no bruit noted, no swelling noted to lymph nodes. Respiratory wise, she does have some decreased breath sounds, however, she seems to be aerating well. Symmetric expansion. Cardiovascular, S1, S2 auscultated, no S3, normal capillary fill. Current EKG displays sinus rhythm at 73 beats per minute. Again, no ectopy noted. Abdomen was soft without masses, no organomegaly. Bowel sounds times 4 quadrants. Extremities, non-pitting edema noted, bilateral upper and lower extremities, bilateral 2+ radial and pedal pulses. No clubbing, no cyanosis noted. Triple lumen PICC line noted to the right upper arm. No swelling or signs of infection noted to the site. Left radial arterial line in place. Dressing is clean and dry. No signs of infection noted to the site. Neuro-wise, extraocular movement intact. Perla noted. No speech output at this time due to intubation and sedation. Positive doll's eyes, positive corneals. Withdrawals from painful stimuli, however. Reflexes 2+ to bilateral biceps and patella. Currently, she is a GCS of 4. Again, she is sedated. The genitalia, 16 French Foley cath in place, secured to the right thigh. She is draining clear yellow urine. Skin is warm, dry, and intact. Current ventilator settings, she is on pressure control, FiO2 100%, rate of 18, PEEP of 10, tidal volume of 550 at this time. Pertinent labs include AVG of 7.37 pH, 40 PCO2, 23.1 bicarb, 98% O2 set, base excess -2. Her sodium right now is 145, potassium 4.4, chloride 110, BUN 45, creatinine 2.2, calcium 7.9, and mag is 2.4. Liver enzymes are slightly low, AST 15, ALT 10. Her albumin was 2.0, and glucose is 120. White counts slightly elevated at 14.07, and hemoglobin 7.9, hematocrit 25.7. Platelet count 302. Impression, acute subarachnoid hemorrhage that is most likely precipitated by malignant hypertension. Severe acute respiratory failure. Patient is reintubated and on ventilator. Non-oliguric acute renal failure, probably secondary to malignant hypertension and contrast nephropathy. Left lower lobe, beta hemolytic strep species, aspiration pneumonia, morbid obesity, anasarca. Current plan right now is to continue treatment and management of the patient in neuro ICU, full ventilator support with PC mode, check arterial blood gases serially, continue with LASIK drip at 10 milligrams per hour for fluid overload. However, we have to consult the pulmonologist regarding being weaned off the Lasix because the patient is in the vasospasm window. Follow-up angiogram rescheduled for tomorrow. Nephrology consultation for the elevated BUN, creatinine, as well as the anasarca. Continue cardian drip to control malignant hypertension. Titrate to maintain systolic below 140s. Monitor patient's neurologic status closely, which includes ICPs in 10 to 12 range. We'll use 23.4 saline to manage ICP elevations greater than 20 and staying elevated for greater than 5 minutes. Avoid mannitol due to kidney issues at this time. Maintain normothermia, cooling blanket. If this fails, we'll consider scheduled Tylenol. Normal glycemia. Patient on Levemir right now, but we'll place on aggressive sliding scale.